Hi all, greetings from Christian Medical College, Vellore. I am Dr. Satish, working as a professor and head of the unit for Cardiothoracic Anesthesia in Christian Medical College, Vellore, Tamil Nadu. Today I am going to talk about thoracic paravertebral block. See, thoracic paravertebral block is one of the main regional block for all cardiothoracic surgery for very good perioperative analgesia. I will first go with the anatomy. The first one is the muscular anatomy. If you notice in this picture, this is anterior and this is posterior, and the muscles are trapezius, rhomboides and erector spinae. You see the spinous process of the vertebra and also the transverse process of the vertebra. Our area of interest is the paravertebral space where we need to deposit our drug. The arrow marks the paravertebral space. Basically, if you want to give a block in the paravertebral area, your needle should surpass all this muscular layer and go across the transverse process of the vertebra, and you should deposit the drug in the paravertebral space. If you do thoracotomy or minimally invasive cardiac surgery where you do only one-sided incision, unilateral is enough. But if you do stenotomy, you need to give bilateral paravertebral block. This is a skeletal relationship. If you notice, as an anesthetist, we all know the spine of the thoracic vertebra is very sharp and descended down, and also significant angulation of each vertebra on the thoracic level. In this picture, I would like to highlight the spinous process of a vertebra in thoracic area corresponds to the transverse process of the lower vertebra. Suppose if you want to give a block at T3 level, then you should choose T2 rather than T3, because if you choose T3, then the corresponding transverse process will be T4. Ideally, for cardiac and thoracic procedures, we should either choose T4 or T5 vertebra, because that is almost at the midpoint of the thoracic dermatomal distribution. Next important structure that we should know are ligaments in paravertebral space. The most important ligament that we commonly come across when you do with the landmark or paramedian approach is superior costotransverse ligament. The name as such suggests it's a costotransverse. It connects the costochondral junction with the transverse vertebra from the above and below level. Same thing, you have intertransverse ligament and also lateral costotransverse ligaments. So basically this ligament prevents the muscle layer from the paravertebral space. These are the boundaries of paravertebral space. The anterolaterally parietal pleura, posterolaterally superior costotransverse ligament, medially by vertebra, intervertebral disc and intervertebral foramen, superiorly by the inferior aspect of the head of the rib and inferiorly by the superior aspect of the lower rib. Next important thing is the division of the nerves from spinal canal. As we all know, as an anesthetist, when you give spinal or epidural, you know this is a spinal column and the nerves comes anterior and posterior divisions comes and form a single ganglion, that's a sympathetic ganglion, and then it divides into ventral, dorsal and also ventral rami. Ventral rami come across all these things and give all ticks along the way. So if the paravertebral space is just anterior to the transverse process, so when you give a block at this level, you are blocking all the ventral and dorsal rami, and some of the drug can descend down and up and block the sympathetic ganglion also. So it's a very effective block for any thoracotomies, or even if you do a midline stenotomy, if you give bilateral, it will work very effectively.